All right, we'll move on to our voting. So if everyone can take their seats, our federal and non-federal members.
Recording in progress.
All right, so welcome back to our final stretch of our NAPA meeting. Again, thank you again to all the subcommittees for their hard work in preparing the recommendations and presenting those today. So we'll just go ahead and call the meeting to order, and then again we'll be voting on the recommendations that were presented. Non-federal members are the ones who can vote. So for those of you online, you want to do something creative like a thumbs up or show your camera and just do like a raise your hand if you're in agreement. So if everyone who's in agreement with the recommendations as they've been proposed, if you're in agreement with them, if you could just say aye. Those are here. Okay, and everyone online, if you want to again just kind of indicate if you're in agreement with the recommendations of the non-federal members. Okay, good, thank you. And anyone opposed? I don't see any thumbs down or anyone here. Great. All right, so let the record stand that these were unanimously approved by the non-federal members. Thank you all again. So our last two orders of business are we will be shifting, so we'll have some members rotating off, including myself. And so Helen's asked us to each share some remarks from our departing members. And if we have a little time afterwards, I would like to gather some information on suggestions for how to better orient the new team members who will be coming on, which I think are still in the works. So we don't know yet who will be the next committee members. So I guess I'll start then before my coughing starts up again. But again, I just want to thank everyone so much. It's been a great experience being able to work with everyone here, and I've learned so much from each of you, from the experience everyone brings, from the learning about the federal infrastructure. I've learned a ton from everyone here. And again, I think, having been on the committee for 4 years now, the council, if you think back, we started in October of 2019. So before there was COVID, before there was heightened awareness of health inequities across our country, before there was any approved therapeutics for Alzheimer's disease. So really, over these last 4 years, I think COVID really brought to our attention the vulnerability of our patients who are living with Alzheimer's. Again, the higher death rate that we saw, the isolation that was seen among caregivers, the negative impact of isolation on our patients. And so again, reaffirming the need for good social interaction, good social support. So the encouraging side of that is I think we're seeing, even today during the meeting, we're seeing responses to that. So, ACL having a program that's going to connect people with living with dementia. A lot of community organizations are trying to help people get connected. We're seeing more and more use of creative ways to keep people connected. So, with COVID, obviously we realized we needed more telemedicine, use of video medicine that had been kind of held back, and that's in the forefront now, even to the point where we can use videos to project AAIC meeting, like Dr. Pike brought up earlier, that we can have more people engaged with research, more people engaged with clinical care. So again, some silver linings coming out of COVID, as we've all seen. With the staff shortage we've heard about today, with Indian Health Service, there's still staff shortages as a result of COVID, which has really heightened our understanding that we need more creative ways to help use team members' time. So even things like the care navigators we've heard about today that'll be part of the new CMMI program, and then just rethinking ways to use people's time well to provide good dementia care. So in a way, it's shaken up our approach to dementia care, but also given us kind of new perspectives and ways we can do these things. And I think, as Joanne mentioned too, during the risk reduction, I think a heightened awareness of the health inequities in our country, and especially among dementia care. So I think it's really encouraging to see the recommendations talking about improved training of persons from diverse backgrounds in research and clinical care, better representation of people from diverse backgrounds in research, clinical care, and not just racial and ethnic minority adults, but also people from Down syndrome community, other intellectual and developmental delays, people with neuroatypical syndromes, early onset. So really trying to think about those other communities So I think that's, again, hopefully something we'll keep pushing toward is better health equity across these programs. And then research advances. I mean, we're thrilled, again, over these 4 years, we now have our first fully FDA approved therapeutic to treat the underlying cause of Alzheimer's disease. But I think we all recognize it's not enough. There's, again, it slows down the progression, but it's not going to cure the disease. So, but we have newer tools. We have new diagnostic tools, biomarkers that are getting to where they're more accessible through blood-based biomarkers that have expanded in the last 4 years. So helping us to identify and kind of tailor therapies to patients is really encouraging. And then also research on these models. So we're seeing these models of care, clinical care, seeing models of public health outreach, engagement. We're seeing the recommendations, as mentioned to Dr. Ortega, the recommendations about getting caregivers involved into clinical care. And again, CMS providing some caregiver training along those lines, trying to really, seeing the impact of some of these recommendations on a lot of the recommendations that were brought forward in RFAs coming out. So again, it's been a great privilege to work with all of you and to see the progress. It's nice to reflect. I think we reflected for our 10-year appointment, but even just over this last year, a lot of big breakthroughs, and even just within today's presentations, a lot of things to be grateful for and excited about. So I will stop there, and I think they have. I'm just going to read the order that that Helen gave us. It is random. So Venerine Brown-Broadswain, if you want to share some comments.
Good afternoon, all. It's hard to believe it's 4 years since we've joined this committee. Seemed like time went by. I had some illness in between that time, and I also took care of my mother, who was very ill at that time. So it seemed like the time was shortened. However, it is an honor to be on the committee, and I extend my gratitude for the opportunity to participate. The committee provided me with opportunities to learn about the various research that is going on, to hear the reports from various committees in terms of what is being done, and has opened my eyes to the larger world of dementia and helped me to see the disparities of people of color. I came into this committee as a caregiver, and I'm leaving feeling like I hardly contributed anything to the committee. Part of what it is that I came in, I am in a full-time job in a field that is not related to this entire process. And coming in, it was hard to know what is expected of me because there was no orientation. I came in with lots of enthusiasm that as a person who deal with equity, that this could have been addressed. But this committee is very, very technical. And for a caretaker to be a part of it who is not familiar with all the technical terms, it took me a while, a long time. I can say for the 4 years that I'm on this committee, this is the first year like I felt like I know what this committee is about. So that is something that needs to be addressed in terms of the technical aspect of it. As someone who is very passionate about equity work, oftentimes I hold myself back in terms of asking questions or even responding, because my thought and ideas would be often I feel was in the minority, and I didn't want to be seen as someone who's negative. It's hard to not be enthusiastic about some of the things that you hear. But for example, last time I was in person at the last meeting, when there was some information provided in terms of these 2 new drugs that was being debated, and they were going to be getting approval, and they have been getting approval, only to read later that a lot of the individuals of color who went through did not go through the trials because they did not meet the requirements. So as a member of this committee, there is no way that I could have known that. I don't understand enough about what is happening. I'm not prepared before to be able to offer that. And while I love the idea of a caretaker being on it, we need someone who have more knowledge and can present more. or that they're included into the discussion. No one stopped me from making any suggestion, but my suggestions, since it's so technical, is always, oh, okay. And then you move to the technical aspects of things. So that is one of the things that I would strongly recommend for someone coming onto the committee. I'm leaving, still committed to the group, but still feel like while I hear the word DEI being used far more than I did when I started, I'm not sure that individuals understand fully what that means. I think sometimes it's just a matter of saying the word, having pictures, making statements, but not really, you know, we still continue with business as usual, because it's so systemic in terms of what it is that we're doing that, you know, just saying the word and doing those things, how are we really making the change? And that's where my interests lie. And I'm not sure that in the committee that I was able to ask those type of questions or go even deeper with that. But I am grateful to be there. I now have a better understanding of what the committee is doing. I try my best in my local, where I have some control in the local community, to do a little bit more and to understand a little bit more so I can be more effective here. So thank you for the opportunity.
Thank you, Venerine. And again, I think your voice has been extremely important in our group. You're sharing your story as a caregiver, sharing your individual experience, and really has shaped me and how I think about each patient's unique experience. So coming from the Caribbean, having different interests that your husband had, having young onset dementia. So I think there are a lot of things that you've said that have really influenced a lot of us. And also just your honesty now, I think, is really important, because you are the type of voice we need on this committee, because we should be able to make things clear. So those barriers shouldn't be there to have caregivers on the committee who can contribute. And also that we need to make sure that all of our members' voices are heard in our subcommittees and our committee meetings. So I really, really appreciate your honesty and your contribution to the committee as a whole and your subcommittees.
Thank you.
Maria Ortega.
I just want to say thank you. Thank you for, the opportunity to be here, to get to know all of you. I still cannot believe that I've been sitting here and learning, from you and with you. Such, experts and caring, like I said before. Now all the C's are extended to all of you, not just the clinical care subcommittee. And yes, a lot has happened, in the last 4 years, personally, right? I have a different last name. So, in case you haven't noticed. And so I celebrate, my growth, the challenges that, being in this wonderful committee has, presented for me, and also how I have been supported by all of you to overcome, the challenges and to grow. So, I take all the lessons to my Florida, Boca Raton, and expand that to communities that don't have access, to what you, have been doing, and also to teach students and to teach medical students about, person-centered care, social work students, nursing. So I said, I'm just going to say thank you, but, I thank you for everything.
Thank you so much, and for leading our subcommittee and for really pushing us to think about caregivers in the context of clinical care. And Carrie Mulkey.
Hello. Yes, I'm just reflecting on my time. And I too, like Venerine said, I cannot believe that it's been 4 years that have passed by so quickly. In fact, I had to ask Helen, am I at my 4 years? And she affirmed that I was, and I felt so sad. And I think there's a couple of reasons why I felt sad, is because it really has been an amazing time to have been a part of this particular committee. Cindy, you mentioned that we all started in 2019 before the world changed as drastically as it did. And I have felt honored to be with a group like this who stayed committed through all of the trials and tribulations of the last 4 years, and to really stay committed and passionate and really looking for ways to improve the lives of people that we serve. And I just find I just am full of such gratitude, just with the knowledge that there's so many people like all of you, and even more that are out there, that will keep going, that are doing this incredible work in all these spaces that, in ways that many of us will never know or learn. And so it's really just humbling and a true honor to have been a part of it. I think one of the early conversations that we had was, as we were thinking about establishing recommendations for the LTSS committee, we had a conversation about whether it's okay to put moonshots, it was called moonshots, into our set of recommendations. These were the things that just felt so unreachable, but were so critically important and really the outcomes that we're striving for. So we talked about, having a cure by 2025, having treatments by that time. And while we're not completely there, we're certainly not there, but it's also not 2025, and a lot happens in a year. Anyway, nonetheless, it was just really neat to dream with this group, and then also think about real practical ways that we may be able to influence this work to better the lives of people with dementia and their caregivers. And I want to echo perhaps, or tap in, or just, reinvigorate the powerful words by my colleague, Venerine Brown Boatswain. Just really want to make this a council where people do feel ready, and it's a space to contribute. So really appreciate you for sharing those words. And I just, one thing that's challenging, and I share Venerine's concern about, when I started, just not having any sort of orientation was a little bit challenging. So just trying to figure out exactly what the group did, what our purpose was, how we could contribute. And so really express some gratitude to Cindy, Dr. Carlson, for starting that orientation with groups afterward. I think that is a powerful way to help people know how to engage better right from the start. So really want to say thank you to Dr. Carlson for leading this group and for the efforts to orient us and get us moving in the right direction to try and make change. So just thank you. Thank all of you for coming together in shared purpose, and I can't wait to see what this council and all of our federal members and others are able to accomplish. So thank you so much for letting me be a part of this last 4 years.
Thank you so much, Carrie, and for your leadership of our LTSS subgroup and bringing your state experience and other Wisconsinites. So I'm thrilled about that. Thank you. All right, we'll move on to Matt Janicki.
Yeah, it's interesting to be able to perhaps echo what some of the other people have already said, and I appreciate what their feelings have been. I have an interesting history because I've been coming to these meetings since the beginning of last decade, when you first started a meeting over at on Mass Avenue with the first meeting, and kind of watching the evolution of the council as it grew and became a very viable force in policy of this country, and very honored in many ways to have been chosen to be on the council as a kind of a highlight of my career in the field. I recall when I worked for New York State, I used to run advisory councils for the state, and it was never at this end. I was over at the other end, but this is a wonderful experience to have been part of. And one of my comments, I guess I want to make is, it was interesting to see representing sort of the interests of intellectual disability and developmental disabilities and disabilities in general from the beginning. The small mention that was focused in the plan and mostly around one particular condition, and now how it's evolved into a broader understanding where the needs of people with disabilities are infused throughout all the recommendations. I was doing a highlighting through the documents today and picking up the places where it's showing up. And I'm very pleased that that's happened because I think it does show that we're concerned with, all sectors of our society, and particularly those people that sometimes are disadvantaged in being recognized as having a neuropathology because they have other preconditions, and the nature that we have to go through. And it's interesting also to see us, as Carrie mentioned, we're on the cusp, I think, of some major breakthroughs in terms of recognizing how medicine can begin to conquer this disease. And it has great meaning for us in the field, particularly for those families who are, concerned about sons or daughters who have Down syndrome, who has the highest risk factor of any kind of condition. And the fact that someday, in some generation, people will be able to get some type of medication early in life, which will prevent them from ever having to experience the decline they experience now in their 50s and die early in their lives because of Alzheimer's disease. So I think this council has done a lot of work in that direction. And certainly, I know we supported in general through our organizations the reauthorization to continue the council's work to 2035. And we're hoping that that gets passed and progresses to enable this council to continue to work in these areas and bring all these kinds of factors that we have to concern ourselves with to fruition. And hopefully by 2035, we may see the end of this problem with this disease and obviously other dementias as well. So it's been a pleasure, and it's been wonderful to work, even as sort of I consider it sort of like Grover and Cleveland term, because we started and then stopped for a while with the pandemic and began again. So the 4 years are kind of condensed into maybe 2 active years, And I think that's what Vereen and Carrie were talking about in terms of having missed an opportunity. The one thing I find has been useful, and I think it's going to the Zoom platform during the pandemic has been interesting, psychological experience, because we didn't have that before the pandemic. We didn't communicate that way as phone calls and perhaps other things. And then having to move into this other venue. But what's missing in those Zoom years is the getting together, being with people in the same room, talking, having a chance to chat during the breaks. It's hard to chat unless to go in the chat room on a Zoom and have a private conversation with someone and, just chat around, find out what's going on in their lives and also find out what's happening in their field. So I think that this hybrid model that we do have now where people are on the Zoom and also you're able to come here is very important. It creates that personal touch to being a member of a group. And so it's important, I think, if you carry that out. The only thing I could leave you with in terms of recommendation is maybe take a look at a different vendor for reimbursements. I don't know.
So for those of you who don't know, our non-federal members service special government employees. So they are reimbursed through the same system as government employees who travel.
Right. Anyway, I jest, but I think it's an interesting experience. I mean, I have the same experience with the state of Illinois where I get some of the reimbursements. Anyway, so it's been a pleasure, and it's been a pleasure meeting many of you, knowing many of you, and observing the evolution of this group over the past 12, 13 years. And I hope to be able to pop in occasionally again during the public comment period and offer a couple of my 2 cents and 2 shekels, as it were, of commentary. Thank you very much.
Thank you, Matt. We really appreciate your reminding us about the intellectual and developmental delay community, the Down syndrome community, to make sure that we're continuing to think about them and as we approach these recommendations. So you've really been a great advocate for making sure that stays on our radar. So thank you for that. And last but not least, Joe Montminy.
So I had a few things I wanted to say, and I said, I need to write it down to make sure I don't forget some of these points. So I apologize in advance because I was finishing it last night. But I want to start off by saying, it's been an honor and a privilege working with all of you, seeing your contribution and your commitment to helping those of us living with the disease, our families, our caregivers, to me has really been amazing. You know, you work hard and you leverage your experience and your advice, and you support each other in ways that have really inspired me. I think it's been phenomenal. I'd like to express my deep appreciation to the federal partners because the depth and breadth of the government program services and the assistance you provide is far beyond what I could have imagined. And to our non-federal members, you know, your expertise and your personal experiences that you've shared really help. I think it's how enabled our council to better meet the needs of people living with dementia. And I know I've personally appreciated the guidance and support that I've received. You know, in looking at the updates to our national plan, none of that would have been possible without the contribution and even the dedication. You know, if some of you could have seen the number of iterations with some of our recommendations, and more importantly, the federal members taking the time to go through that and give us comments on, not sure if you can do that, but you can. They were taking long, like nights and weekends to help us make sure our recommendations were reasonable. And so that was greatly appreciated because I know we don't say that enough. You know, I truly believe that you have some of the most important jobs in our nation because what you do, everybody on this council does, impacts the individual lives of millions of people. You know, when I was working in the business field, those jobs helped businesses to succeed. But what you guys do help people with living with dementia and their families survive. And that's amazing. You really think about the impact you have. And I really wish more people could really appreciate what you do and the impact you have on us. Now, switching over to just the environment we're in, I really think this is a revolutionary time for Alzheimer's research, diagnosis, and treatment. And this council is really uniquely positioned to lead our nation's effort to navigate through some of these groundbreaking discoveries. And I know they talked a little bit about the revised NIA Alzheimer's clinical criteria that were introduced at the AIC 2 weeks ago, but they really were like groundbreaking when you look at the impact it's going to have on the diagnostic process. And they're expected to be out later this year. So for risk reduction, for clinical care, once those come out, I would hope that those subcommittees would take a look at those to think through what changes we need to make, because they're now defining Alzheimer's disease biologically, no longer by clinical syndromes. And that is significant from my perspective. To have the ability for a clinician to be able to more accurately diagnose Alzheimer's disease earlier, it's just unbelievable. Because knowing we're going to, if for people who are in the early stages of the disease or may actually be showing signs before they are be able to see they have it before they show signs, can allow them to either do the risk reduction stuff that we've talked about or to get earlier access to these treatments. And that's going to change the trajectory of our disease, which, you think about it from our perspective, is priceless. And the plasma biomarkers, I know we talked about that a lot, but that's going to be dramatically changing the diagnostic process, which to me is amazing. And I know both the research and clinical care talked about the need to do more with disease-modifying treatments. But I think the council really needs to figure out what it can do to help in that process, because it's the first time for those living with the disease have any hope for our future. You have the ability to be a part of making that happen. Because from my perspective, I never imagined that I would see a treatment for Alzheimer's disease or these groundbreaking diagnostic tools. So I would love to see this council take advantage of this important point in time in your position on the council to help prepare our nation for the critical steps we've got coming up in the next few years. And you've got the ability to do that. So I want to end by saying a quote that I saw driving to the airport yesterday, because it said, "It's not who you are, but what you do in life that matters." And this council is doing some pretty amazing things. So thank you.
Thank you so much, Joe. You've really changed us and helped us to remember the patient perspective all the time. So thank you for your important contributions to so many of the subcommittees and your important perspective. I do want to echo thanks to Tisa and Helen and Emma for all their hard work behind the scenes and guiding this process. So thank you all so much. All right. I think before we move on, we have 5 more minutes before we move on to public comments. Any other suggestions that team members have? Again, we started an orientation 2 years ago when I came on as chair and did a few sessions for new council members, orientation. And I think Venerine's comments are extremely important. We need to make sure that we are presenting not only things in terms that are just understandable by people not out or outside the field. So that's extremely important. And we need to think about DEI, not just the terminology, but really how it's going to be actionable. Some ideas I had were trying to, do some more orientation for people about what the different federal agencies do, what their roles are, because I think that's, even as a clinician and researcher, what the different agencies do is still kind of a mystery to me when I came on, and still a mystery to some extent. So that was one idea, but let me hear from others, and we'll take notes, and I'd be glad to follow up with people too on all these important comments. So let's see, Randy.
So I just second your, first of all, the point that was made about orientation, I think could be critically helpful for us hitting the ground running and making the most contributions we can make. I actually felt very similar to the comments that were made about just being lost and not really certain about how anything works. Even as a physician who sees patients and has dealt with medical systems and does research, I think the governmental, the federal, the other systems, all the state systems, there's so much there that if there's I don't know, is there a primer or something, a 30-pager that we could just go through and understand what is the, government medical systems for dummies, some Cliff Notes, anything. It might be really helpful just for us to understand. And maybe it's even an internal document, just a 1-pager or something on each group or agency or who's involved, as well as the scope of what's possible. I did spend some time talking to prior chairs about, what the group can do, what is our scope, what possibilities here. I think sharing that with each new member would be very helpful. And then I have a question. I have to say I'm a little disheartened to see so many people leaving. That I've gotten close to you all, worked so hard for many hours, and now, gosh, you're leaving, and I wasn't asked to make my final comment, so I guess I'm staying.
But more years, you're not done yet.
So I'm wondering, well, who all's coming? If you all are leaving, what is the process for the next generation?
So there are nominations that went out in, I forget how long ago it was, but they were sent out, nominations. So those have been sent in, and then I'm going to turn over to Helen because she knows where things are.
So the package of nominees is with the Secretary's office for decisions. And we would expect to hear, to the point about orientation, hopefully the end of this month, the end of August, so that we would have time for an orientation, but sometimes having a scheduled meeting is what pushes it over the finish line. So it might be further along.
And as you can imagine, I assume it's like I know we went through for our state plan, trying to pick people with different expertise, geographic areas, research, clinical, caregiving. So I know there's a lot of work behind the scenes on that too, and then who's obviously willing to do this. So that has to be the first step. But it's out of my hands. It's with the higher ups. It's out of our hands. It's higher ups.
Wait, can I make one quick comment to Venerine's point? I realized as she was saying it, like I actually sitting here having run NAPA for I don't know how many years, I don't know everything that all the subcommittees talk about. So I really can't think of this advisory council is very unique in many, many ways, but another advisory council that has both the breadth and the depth of knowledge and expertise. So you can be on a call where you're talking about cerebrospinal fluid. That's what I don't know. Or like 1115 waivers in Medicaid, with the same group of people. So I do think that you all should give yourselves a break. Like, it is impossible to know everything that this group covered, but that the level of detail that we get in the recommendations and that this group gets into really is at a point where we're thinking through, like, what are the specific little tiny levers that we can flip in this space, and that ultimately gets it to a more successful place than just, improve access to LTSS. Well, we're getting into how could you do that? What are the specific things that we're doing? So give yourselves a break, because there's no way anyone could write that primer on NAPA with all the depth and the knowledge around this table. Sorry.
That's true, but I think we still can make sure as we talk about it, we feel free to ask questions.
Yes,
what is
absolutely.
that? What is that? Because I'm Googling things while I'm meeting with people too. Like, what is that abbreviation? What group is it? Other suggestions? So Helen.
Hi there. I just want to jump off of actually two, Matt and Venerine. Having sat here and and Matt, you and I have both been on that slow train for reimbursement, but the reality is, if we're going to be able to actually have diverse communities, those that are underserved, we have to come up with a better way to facilitate their attendance and being part of this. If they're coming from a low income community, they are not going to be able to front the costs to be involved with this community, which is being asked of us. So I think that needs to be a really serious consideration by ASBE, HHS, whoever can come up with, I don't care if it's a scholarship fund, I don't care, but something that could be considered so that we can truly diversify and include those people that we really need to be serving the most.
Thank you, Helen. That's a great point. Thank you. Joe.
So I just had a couple of comments, and one's kind of getting back to the orientation, because I remember I got the orientation, but I remember not remembering a lot of the details of what the different committees and subcommittees are doing. And I think either having a handout or just explaining how they work in a little bit more detail, so you understand going into the committee meetings, what's expected if people's doing presentations, what do you expect from the presentations, what's your role, especially federal versus non-federal members on the subcommittees, doing annual recommendations. We didn't talk about that during our orientation, but I was like, wow, I can actually do something here, making sure they understand the role they do play there. And then also what resources available on, like even the HHS website, prior year recommendations, other things that we could go to access if we want to have questions and stuff like that can help us. And then my second point that I think is even a bigger one and has helped me tremendously on other committees and boards that I've been on is assigning a mentor. Because a lot of times you think you've got everything, but there's going to be things that you just don't cover. Having somebody we can reach out to that's an experienced member that is saying, I'll spend 5 minutes, just call me, email me, I'll help answer those questions so that you don't get bombarded, or we don't ask the question because we know you don't have the time to, but we'd love to get an answer to it. If you assign mentors, that has been very successful with other programs I've been involved in. Thank you.
It's a great point. Thank you. And I think, again, we want to make sure that those, like Venerine pointed out too, about coming in with passionate enthusiasm. We want to make sure it's not dampened by logistics and feeling like they don't understand what's going on. So I think, and maybe even the process when people are volunteering for the role, that they have a sense of what's involved. Carrie.
Yeah, this is kind of springboarding off the logistics piece that you were just talking about. So I think one of the challenges is that we are all really busy. Everybody that's a member of this council and also the subcommittees are incredibly busy. So just even finding a time monthly, at least for our subcommittee, we were only able to meet monthly at most. And what we're managing is creating a set of recommendations and also coming up with an agenda and presenters for one of these four, one of the 4 council meetings that we have. And it's actually almost too much to spend, 1 hour a month trying to do both of those really well. So I do personally feel like we didn't have enough time to really dive into the recommendations in the way that I think, our whole committee probably would have wanted to. I don't think there was any other alternative than to take what we had done last year, and make just little modifications to those, and then also think about what gaps we wanted to add this year. So I don't know if there's some way to break apart or, those two tasks of creating the recommendations and planning a meeting, or if there's some additional support that can be offered to at least help with, getting presenters and that sort of thing. Because at least as a subcommittee chair, it was an incredible amount of work. I will say it was a lot of work, and so there will be chairs for each of these committees, but moreover, it's just a lot to try and tackle within a short period of time, with not really having a chance to have meetings more often. So I don't know if we can do anything with that, but wanted to share that.
Thank you, Carrie. I know there've been other requests for more technical assistance to help with certain aspects. So, and again, it is busy. I know some members have talked about setting up templates, some other things that maybe would help it easier as we move forward with recommendations or planning meetings, things like that. But we'll move on to, Rhonda, we'll let you be the last comment, and then we'll move on to public comments.
Mine is very quick, but first, just a lot of gratitude and thanking all the members, but especially those who are leaving us. And I've just been so impressed with the knowledge and the inspiration shared. I think going off of what Carrie just shared is maybe consider co-chairs for the committees and sharing some of the work, both logistically as well as content. And lastly is, it took me a while to, and someone mentioned it today, and maybe it was you, Carrie, around those moonshot items. And learning, I think, through the introduction, that it can be a combination of moonshot and alignment with other moonshot initiatives, potentially in the U.S., as well as those specifics that can really move it to the next level. And that it's so that combination, it's not natural. At least it wasn't natural to me until I realized, oh, you can do either, and that the combination of both can be most impactful.
Thank you. And again, thank you all for your input. And turn it over to Helen, and we'll move on to the public comments.
Thank you. And thank you, everyone, for your feedback. We will definitely take it back as we plan to go forward. And our departing members expect to get a phone call from us asking you to mentor somebody new. So we hope that you come to visit and that you hear from you often. And on that note, I'm going to introduce our first public commenter. I did not set it up this way, but it's actually our former chair, Katie Brandt. So point made, Katie, you are our first public commenter. And after Katie, we have Jim Butler.
Well, just like Matt said, you can come back to Napa. So good afternoon, members of the Advisory Council, presenters and guests. My name is Katie Brandt, and today I'm speaking with two hats. The first is as a former FTD caregiver for my late husband, who lost his life to FTD at the age of 33. And the second is as director of the All FTD Participant and Family Engagement Board. All FTD is a comprehensive study targeting most varieties of frontotemporal lobar degeneration, also known as FTLD or FTD. Funded in 2019 with a 5-year grant through the NIH's National Institute on Aging and National Institute of Neurological Disorders and Stroke, All FTD has more than 20 sites across North America and aims to prepare the FTLD community for treatment trials in FTLD. Our engagement board is made up of enrolled study participants, their caregivers, and those whose lives have been touched by FTLD. Board members can provide feedback on the All FTD research experience and advise on participant and family priorities for research. It's important that these priorities are known to all FTD study staff, as well as the larger community of scientists, clinicians, funders, and policymakers, because this is an atypical young onset dementia, which robs individuals and families of a future together, while also bestowing a devastating financial burden to shoulder the cost of care. Today, we ask that NIH funding continue, not only for the ALL-FTD study, but for FTLD and related dementia research in general. We ask that expanded education is offered to healthcare professionals in many different settings about how to accurately diagnose FTLD, as many individuals living with FTLD experience one or more misdiagnoses, because too often clinicians do not have exposure to young onset and atypical dementias. This steals precious time during the early stage of the disease, when individuals and families can connect with a community of support, participate in research, and discuss values and wishes for future healthcare. I would like to thank the NAPA Advisory Council, not only for letting me be a part of it for 4 years, but for your continued advocacy for research, care, and services for all dementias, building hope that the cure of tomorrow is not so far from the care of today. Our call to action is for continued funding from the NIH for the ALL-FTD study beyond 2024, and for expanded research funding for young onset, rare, atypical dementias. Thank you.
Thank you, Katie. Next, we'll hear from Jim Butler, followed by Jill Sigliana.
Good afternoon. My name is Jim Butler. I was diagnosed with Alzheimer's disease 9.5 years ago, and today I'm speaking with you as an advocate with Voices of Alzheimer's. While we in the Alzheimer's community have much to celebrate recently, I'm here today with one simple message. Our work is far from over. After decades of hard work and sacrifice by many people and countless others, I am extraordinarily grateful for our progress in finally getting treatment for diagnostics for people living with dementia. But these treatments are not cure, and not everyone needing treatment can access it. I urge this community to continue to push and improve rates of early accurate diagnosis. Existing medicine for Alzheimer's are only effective in the early stages of the disease, meaning that once a person progresses beyond early Alzheimer's, they're out of treatment for options. The U.S. government must continue to invest in and drive research that allows for people detection of Alzheimer's at stages of the disease where treatments are still effective. It also occurs that we prioritize identifying as many candidates for treatment as possible and continue eliminating treatment barriers. The treatments surrounding the disease, the cost of treatment, unreliable transportation to distant treatment centers, lack of providers, and for our barrier preventing people from getting diagnosed and treated every single day and reaping the benefits of delays and in the progression of devastation condition. I urge the committee to do all they can to help dissipate the barriers that are there. Every day, thousands of people progress past the early stage of Alzheimer's to the point where the existing treatments may no longer help them. We have a lot to celebrate also a lot to do. I urge the committee to fight hard to get sure that 6 million people living with Alzheimer's, like me, receive the care and the treatment we deserve. And thank you very much for allowing me here.
Thank you so much, Jim. Jill Sigliana, will you come to the podium?
I'm like, Joe, I made notes. Yes. Hello, members of the Napa Advisory Council. Thank you for opening this meeting for public attendance and comment. The work of this council is crucial as our nation looks to respond to the complex challenges faced by people living with dementia and their families. It's been a privilege to be here in person on such a monumental day. I want to thank you each for your countless individual contributions and for your collective work serving as champions for the millions of people affected by dementia. I serve as the executive director of a community-based organization called Memory Care Home Solutions based in St. Louis, Missouri. We've been delivering evidence-informed, non-drug dementia services for families for 20 years. Our community has directly benefited from all of your work. Thanks to funding from the Administration for Community Living's Alzheimer's Disease Project Initiative, we have translated the evidence-based interventions COPE, which is an occupational therapy intervention, and care ecosystem for delivery in our community. The guide model announced today by Administrator Brooks-LaSure will fill an enormous void in healthcare for people living with dementia and family caregivers. I was working as an occupational therapist in a large health system in St. Louis when I began observing the lack of treatment provided through traditional healthcare settings for people living with dementia and their families. Not only are caregivers often ignored in care settings, they are even blamed and criticized for their poor management of their loved ones' other chronic conditions. Patients' acute issues are addressed well in healthcare, but dementia and the long-term management of dementia symptoms and functional decline are largely ignored. And at Memory Care Home Solutions, we still today see hundreds of families each year who share their painful healthcare interactions with us. So I applaud you all for recommendations that would have a transformational impact on the lives and healthcare experiences of people living with dementia and their caregivers. I'm most excited and encouraged to see that the guide model and the codes proposed in the 2024 physician fee schedule highlight and validate the contributions of informal caregivers. I also lead a community of practice on dementia care for the American Occupational Therapy Association. And we did a recent poll of our members, and they were the topic of most concern for them was how to provide and bill for a needed caregiver education. And caregiver education from occupational therapists is generally focused on hands-on strategies that directly support the daily function of people with dementia and the management in daily life of their behavioral and psychological symptoms. We need coverage of caregiver education to reimburse therapists for the time spent with families on these issues, which are so central to quality of life. And there are a few disciplines within healthcare that focus specifically on things like safety in the home environment, performance of everyday activities, and meaningful engagement in activities specifically to reduce behavioral and psychological symptoms. So I hope that occupational therapy will be considered as an important part of any interdisciplinary team for comprehensive dementia care. And in our navigation model based on care ecosystem, we utilize non-licensed navigators who are supported by a clinical team of occupational therapists, social workers, and pharmacists who work in coordination of care with patients' established primary and specialty care providers. So without philanthropic support that we raise in our community and ACL funding, these services would not be possible. But the guide model and these recommendations that you all have discussed today would allow for dementia to be managed and covered within healthcare benefits, similar to other chronic health conditions. This level of access to care is a gift to celebrate. It's important to acknowledge that community-based organizations like ours are deeply entrenched in our communities. We represent and reflect the voices of the people that we serve. And we have deep knowledge of the resources available in our regions. Many community-based organizations are billing services through health insurance benefits, are already delivering evidence-based programs, and are poised to participate in these models and recommendations. So we at Memory Care Home Solutions look forward to the bridges that will continue to be built across communities, providers, state and local governments, and federal agencies to make all of your recommendations a reality. Thank you.
Thank you, Jill. Next, we have Hampus Hillerstrom, followed by Kayla McKeon.
Hi, everyone at the Napa Council meeting. I'm Hampus Hillerstrom. I have a 9-year-old son, Oscar, with Down syndrome, and I'm also the president and CEO of LUMA and IDSC Foundation. LUMA and IDSC is a leading national nonprofit organization accelerating Down syndrome research and empowering 300,000 families in our online community. Adults with Down syndrome are genetically predisposed to the early onset of Alzheimer's disease with a lifetime risk of 90%. Ironically, I'm not worried that my son Oscar will get Alzheimer's disease because of the exciting disease-modifying drugs that are approved or nearing approval by the FDA for early Alzheimer's disease, and also the future prospects of treating earlier and combination therapies that will come along as well. However, the clock is ticking for adults with Down syndrome that are currently in their 40s and 50s. So we're working with urgency to stop progression of the disease in that generation of adults with Down syndrome. As mentioned in the public comment at the May Napa Council meeting, LUMA and IDSC, the NTG, and a group of 20 experts in Alzheimer's and Down syndrome have been working on equivalency criteria for treatment access to the class of anti-amyloid Alzheimer drugs for people with Down syndrome. The expert panel concluded on 4 key adaptations needed for the Down syndrome community. First, age. Adults with Down syndrome are symptomatic at an average age of 54 years, but some get dementia in their early 40s. Therefore, access needs to account for the earlier onsets. Second, assessment scales. Cognitive, behavioral, and functional assessments are not sensitive enough for use in individuals with Down syndrome. Thankfully, assessment scales have been adapted for people with Down syndrome, and the expert panel recommends their use. Third, contraindications. Seizures, certain immunological diseases, and hypothyroidism are very common in adults with Down syndrome, whereas severe mental health issues are very uncommon. The expert panel recommended adaptations for our population regarding these possible contraindications. Fourth, the safety data in our population. Our query of clinicaltrials.gov showed that in 30 clinical trials with 17,000 participants with Aduhelm, Leqembi, and donanemab, no one with Down syndrome was included. The expert panel therefore recommends the conduct of safety trials in adults with Down syndrome, so clinicians and families feel more comfortable prescribing and taking these drugs for our high-need population. To conclude, Alzheimer's disease is the leading cause of death in adults with Down syndrome, accounting for 75% of their deaths. We ask that the Napa Council, the pharmaceutical companies, and all other stakeholders have the Down syndrome population on your mind in everything you do, so that barriers to equitable access to the latest Alzheimer's therapies are removed, and that safety trials are conducted as soon as possible with these promising drugs. Thank you.
Thank you, Hampus. Next, we have Kayla McKeon, followed by Terry Walter. Kayla?
Hi, and thank you for having me here. I am very honored to speak to all of you on the council, so I appreciate it. And these are my comments. However, as you may know, the vast majority of individuals with Down syndrome will experience brain changes associated with the early onset Alzheimer's disease. Many of these individuals will lose the skills and abilities they worked so hard to achieve and will require increasing assistance from others to care for themselves. I have a friend who is currently experiencing an early onset of Alzheimer's disease and is deteriorating quickly. And yes, it is a scary reminder of what could happen in the future. To me and others, if we don't make discovering a treatment and a cure for Alzheimer's disease for those with Down syndrome a priority. I was thrilled to hear that drugs that slow the progression of Alzheimer's disease have begun to be approved by the FDA. However, it is also discouraging to hear that no individuals with Down syndrome were included in the safety trials. Because of that, physicians will not be able to confidently prescribe these potentially life-extending medications to individuals with Down syndrome, despite it not being approved for the general population. And it is incredibly vital that individuals with Down syndrome are given the chance to be included in clinical trials for Alzheimer's disease, so they too can have safe access to the newest, most effective drug treatments for Alzheimer's disease. Thank you for your continued support as we work to improve our community's access to accurately and timely diagnosis, care, and inclusion in research. Continue to keep working to make healthcare equitable for everyone. Again, thank you very much for letting me speak. I really appreciate it. Thank you.
Thank you, Kayla. Terry Walter is up next, followed by Katie Zanger. Terry?
Good afternoon. I'm Terry Walter from California, and thank you for letting me speak with you today. It is an honor for me to share the Walter family story, my story of FTD and ALS. This journey will be one of the hardest that the patient and family will ever take. FTD is a brain disease, not memory. It affects one's personality, behavior, speech, and movement, most commonly occurring in ages 45 to 64. However, it can reach from age 20 to 80. Our family's journey started in 1981 with a diagnosis of ALS with a mother and ended in 2007 with the passing of my husband from the FTD and ALS, a 26-year time frame. Today, we have 8 children and 15 grandchildren that are at risk for developing the genetic form of FTD and ALS. This is why I'm so passionate about FTD and finding a long life cure. Because my husband and his brothers were diagnosed in the early stages of FTD and ALS, and the fact that we live so close to San Francisco, they were able to participate in research as often as possible. Because of their participation, the C9orf72 gene was discovered. The positive outcome since 2007 is the Walter family has come together to bring awareness and hope to finding a cure for FTD ALS. Today, I'm super excited to hear about the Healthy Brain Initiative. As with most diseases, early detection is critically important. Unfortunately, the genetic version of FTD and ALS affects individuals that have the gene prior to the start of symptoms, which is why starting early treatment is critically important for them. That is why I believe the FTD and ALS and all other brain degeneration should be included in the Healthy Brain Initiative. Thank you for taking the time to learn about this and to hear my story.
Thank you, Terry. Katie Zanger?
Yes, good afternoon, y'all. How are you? Good afternoon, members of the NAPA Advisory Council. Thank you so much for this opportunity to speak. And thank you, Terry, for sharing your story and your family's story about FTD. I'm also here. My name is Katie Zenger, and I'm here as a volunteer ambassador with the Association for Frontotemporal Degeneration, or AFTD, and I represent the state of South Carolina. My father, Stephen Zenger, died of behavioral variant FTD complications in early 2021. I'm also here, however, in my professional capacity as a public health professional and practitioner. I'd like to officially commend the CDC on their excellent work on the newest Healthy Brain Roadmap series. It is an excellent document, and a number of things are well corrected from the last version, especially the moving the community partnerships reordered to number 1, because that's absolutely critical to the movement forward of this work, and to not duplicate efforts, especially when we have such limited public health resources. South Carolina was a BOLD grant recipient in 2021-2022, and I was part of the team that worked on our new 5-year South Carolina statewide plan to improve dementia care and services and improve risk reduction and early diagnosis efforts across the state. I just would officially like to say I'm glad to see the shift towards the use of a more umbrella language of dementia and away from the term ADRD, which stands for Alzheimer's disease and related dementias. During our work to review data and develop a new strategic plan to address our South Carolina specific concerns around dementia, became acutely aware of the importance of language around this and in the field. I think it is critical that we move away from ADRD as a term. I know that this can be difficult as we, federal things move differently and more slowly than we'd like sometimes, but I just would like to say that the ADRD as a term becomes problematic for 2 reasons. One, it perpetuates that assumption by the general public and by many healthcare professionals that dementia and Alzheimer's are exactly the same thing, promotes that conflation of the 2 concepts. It makes it more difficult when that happens to have care, have understanding, and for folks like me and my family to access care for the less understood and less prevalent types of dementia like FTD. I've experienced this as a caregiver navigating the healthcare system while taking care of my father with behavioral variant FTD, and as a public health professional while I worked with state agencies to improve understanding of dementia and the needs of folks caring for people with dementia across the state. So secondly, as a public health professional, as an advocate for the AFTD, I feel using more precise terminology of dementia as the more umbrella term, but then moving away from Alzheimer's disease and related dementias and instead naming those subtypes more concretely, that will allow us to, that reflects the current science and use more precise terminology. And I think it's critical both that we're doing that in epidemiological research, and then of course for future versions of ICD-10, in all kinds of insurance coding. Currently, we need to do a better job of collecting accurate data for these less common dementias, especially FTD, in registries across the country, including in South Carolina. Ours is even called the Alzheimer's Disease Registry and barely includes enough information on the different subtypes. So accurate early detection, diagnosis, and treatment of individuals with FTD depends on our understanding of the incidence and prevalence of the disease, as well as healthcare providers' awareness of those different types of dementias and how they progress. Research funding and early diagnosis and risk reduction efforts are also going to be greatly and positively impacted if we have a system where non-Alzheimer's dementias like FTD are correctly understood and correctly measured. So thank you so much for your consideration of this very specific recommendation that I'm putting around language. And I'd also like to thank Terry for sharing her story. And I'd also like to echo Katie Brandt's excellent comments at the beginning of the session today. Thank you for your consideration of continued funding for the All FTD study, which is critical to this kind of work. Thank you all so much.
Thank you, Katie. And the last speaker I have on my list is Nancy Lundberg from AGS, but I don't see her in person, and I don't think she's online. Okay, we'll look for her comment in your email. Thank you, Cindy.
All right, again, thank you so much to our public commenters. We really hear your voices and take those into consideration as we have discussions in our subcommittee. So thank you all very much for all your input. We really appreciate you taking time to present to us today. With that, we'll finish up our meeting. We've had a lot of great discussions today, a lot of exciting advancements this morning, kind of a thought, step back and see where we've come, and a lot of great movements going forward, a lot of good initiatives clinically, research-wise. And again, thank you. We know the work's not done, so we appreciate our public commenters and making sure these things stay in our radar. So with that, I'd like to thank everyone for your contributions today. Our next meeting will be in October, and that will be announced as we have the new leadership or council members announced too. So that'll be confirmed and sent around. Correct? All right, anything else? All right, thanks everyone.
Produced by the U.S. Department of Health and Human Services.